All right. Hello, everyone. I'm Judy Hervey, and I'm going to be discussing here intrapartum care of the mother and fetus, which encompasses everything during the actual labor and delivery of the mom. And of course, we're not going to be able to cover all of it, but a lot of facts and figures in here because of what we do. We are in application science. So, without further ado, here's the objectives that I'm going to be talking about. And before we go any further into this, let's talk about intrapartum fetal surveillance. And what that means is what are we looking for? What are we watching? And the purpose of it is basically to provide a safe environment for both the mom and the babies. And in doing that, we're going to minimize the risks to them. We're going to support the mom and the family through this whole process, and through especially the labor and the birth is what we're all here for. Offer reassurance, comfort measures, very, very big. Pain, both pharmacologic measures to help reduce pain and non-pharmacologic. We have to remember that this is the same no matter what culture you are. The baby has to come out one of two ways. It's either cut out or it's pushed out. And so with that in mind, there is a good deal amount of pain. How people respond to it is very, very different, but we still have to be there to reassure them and to comfort them in any way that we can. And then promote a positive birth experience. I'm going to be talking about many different organizations that actually are part of our clinical guideline backbone of this wonderful wonderful specialty that we call obstetrics, that encompasses antepartum, intrapartum, and postpartum. And one of them is called AWHONN. It's AWHONN. And what that stands for is Association of Women's Health, Obstetric, and Neonatal Nurses. So AWHONN is basically all the nurses. They're the OB nurses. Again, Association of Women's Health, Obstetric, and Neonatal Nurses. ACOG is going to be the doctors. ACOG, ACOG. It's American College of Obstetricians and Gynecologists. And then NICD, you're going to see throughout this, is National Institute of Child Health and Human Development. So they all weigh in on many, many different practices and procedures that we do in this area. And so now this takes us to this screen, our intrapartum fetal surveillance. All that means is we're watching, we're trying to help them in observing. And it's very interesting to note that 20% of perinatal morbidity and mortality arises during the intrapartum period. So you can see, that's quite a bit. You can see how keen assessment skills and actually paying attention to what we're doing is key in this area, coupled with the fact that it's highly litigious area for this reason. Goals for fetal heart rate monitoring. Basically, we want to see how the baby's reacting. We're going to assess their fetal well-being to the labor. And also detect signs of any fetal compromise. Have they had it with this whole process? Modes of fetal heart monitoring, meaning how are we going to do this, is through hearing, auscultation, or we have the electronic fetal heart rate monitoring, which we're going to talk about. Objectives for intrapartum care. We know that during labor, uterine contractions compress. They push down on the arteries that feed the uterus and the placenta. And in pressing down on everything and constricting, you're temporarily stopping maternal blood flow to the uterus and the placenta. So it decreases fetal circulation and oxygenation, but just long enough so that the baby can bounce right back. Because again, this is a normal process. Circulation to the uterus and placenta resume during uterine relaxation between contractions. So that's when we really need the mom to relax. And here I've bolded it for you. Evaluation of fetal well-being during labor is accomplished by monitoring the fetal heart rate pattern in relationship to the contraction pattern. How is the baby relating to the contractions? The emotional, informational, and comfort needs of the mother and family must be incorporated into the plan of care while continuing to assess the fetal heart rate pattern to the response. How is the baby responding to the labor process? Fetal heart rate and uterine contractions can be monitored manually or electronically, as well as externally and internally. And hopefully you will all see this in the clinical setting. Normal reassuring fetal heart rate is between 110 and 160. That's where you want to see it. Every once in a while, we'll get a baby that's around 108 or even 100 if they've just breastfed and they're just like, extended, not too flexed. They're just hanging out because they're so happy. But for the most part, we want them in between 110 and 160, especially during labor, because they're not laying on a beach. And then also 180 is tachycardic. Anything over 160 we don't like. Good variability just means that they're responding to being their head being pushed on. So consists of fetal heart rate accelerations above the baseline of at least 15 beats per minute, lasting 15 seconds or more, with a return to the baseline in less than 2 minutes. So if we've got a fetal heart rate, say that they're around 160 the whole time you've been watching, and it goes to 175 during the contraction. Now remember we said above the baseline. So 175, it lasts about 15 seconds, and it may even stay up there up until 2 minutes. But unless it returns to that baseline of 160, we may have a problem. I hope that made sense. And we could go right in the middle too. If they've been around 120 or 140, we'll go with 140. That seems to be an average of most babies. And say they go to 155 during the contraction, but they don't go back down to the baseline. Now, is 150, 155 still showing good variability? Maybe that's their new baseline. But we don't want them to hang out lower than 110 or higher than 160. And then here it is, the responsibility, that word that nurses are quite familiar with, to assess the fetal heart rate patterns, implement nursing interventions, watch how the baby is reacting, knowing we have these numbers and guidelines, and report non-reassuring patterns to the doctor. Reassuring just means that we know that their sympathetic nervous system is intact. They are reacting to being pushed down on by the contraction. So here are guidelines. We talked quite a bit about guidelines. You guys are going to be doing an exercise in guidelines because we have guidelines to monitor this whole area. For low-risk women during the latent phase, and we're going to be looking at what is latent, active, and the second stage of labor. Latent phase is very, very early in the first stage of labor. For low-risk women, we're going to be looking at the fetal heart monitor every 30 minutes. Active phase of labor, that's when they're like 4 to 7 and we're going into transition. Again, 30 minutes. They're trying to make it pretty simple. Second stage of labor every 15 minutes. This is where second stage is when the baby's being born. So again, it's going to be cut in half because things can go awry. What is going on with that infant? High-risk women, you can see it's cut in half. So they've made it a little bit easier for everybody to remember. A latent phase would be every 15, same with the active. A second stage of labor, high-risk women, would be every 5 minutes. Routine is upon rupture of membrane, either spontaneous or artificially, preceding and subsequent ambulation. And there's, with almost any activity, we're going to be doing a fetal heart rate just to see how they're responding to whatever we're doing to them. And here we go. Here's more guidelines. Guidelines for intermittent auscultation or continuous electronic fetal monitoring would be almost before any activity, before artificial rupture of membranes, or they send a large tube into the vaginal area to break the bag of waters. That's artificial range of or rupture of membranes, and that's what AROM means. SROM is spontaneous, where the water just breaks. But again, we've kind of upset that apple cart, and that uterus was carrying the baby, so we need to see how the baby is responding to that. Before induction or augmentation, after change in any oxytocin rate. Oxytocin makes the uterus clamp down, so of course we need to see, if we're putting even more pressure on that infant, how are they reacting? after any analgesia, any anesthesia, any pain meds, at peak times of medication effect, and after any procedure. Indications for the use of continuous. Now that was intermittent, this list. That's when we're doing it, after or before. This is when, usually this is because there's other things going on. These are higher risk people, multiple gestations. There's a lot of babies in there. Placenta previa or abruption. This has to do with placental problem and placement of where the placenta is. Oxytocin infusion, because it's pushing on the uterus more. Fetal bradycardia, why? But any maternal complications, these are just some that we will be definitely looking at in depth. Diabetes, gestational diabetes, PIHers, pregnancy-induced hypertension, any renal disease, and there are many more. Intrauterine growth restriction, post-dates, meconium, stained amniotic fluid, abnormal non-stress test. Anyway, so that's the list of continuous. And so here is just one of the things we use. This is called a fetoscope or an ultrasound transducer, and most of them all look the same. They're handheld devices that you can actually go and, circle around the mom's belly, put a little jelly on it, and you can get the fetal heart rate. And this is intermittent. Obviously, it's not plugged into anything. And it also helps you palpate the uterus. Electronic fetal monitoring provides a technique for assessment of uteroplacental physiology and the adequacy of fetal oxygenation. Basically, is the baby getting oxygenated? Consistent nomenclature for fetal heart rate patterns are used in the clinical setting to avoid miscommunication between clinicians or doctors, midwives, people that are delivering babies. And this all came about with the 2012 National Institute of Child Health and Human Development guidelines. They have not been changed. This is all since then that they came up with this. And that, what that is this goes way back to this. This is part of the nomenclature, how often we're going to be doing the fetal heart rate. And here you can see at the very bottom, this NICHD 2012. When we're going to use intermittent or continuous, that all came from that. Okay, so in evaluating labor progress, how are they coming along? How, what's happening with the baby, the mom? And we have things that we call TOCOs, and you can see why it's called TOCO. It's a tocodynamometer and or an ultrasound. Those are all external on the outside of the uterus to see what's happening. Internal devices, we have an intrauterine pressure catheter, also known as an IUPC, and a fetal scalp electrode. The IUPC has several benefits over the TOCO because it's inside. It gives you more of an exact pressure of the inside of the uterus. Very, very important for a patient who's having or attempting to have a VBAC, or what that means. A VBAC, V as in Victor, BAC, is a vaginal delivery after a C-section. Vaginal birth after a C-section. And now they're trying for a vaginal birth because we don't want that uterus to be so pressured that it ruptures. So very important for that. And the cervix has to be open, usually around 4 centimeters before we can put that fetal scalp electrode in on the baby's head. And again, method of monitoring depends on institutions' policies and risk factors for mom and baby. What else is going on? Okay, I'm going to stop right now and end this video, and we will start again in just a little bit.